Welcome everyone to the Ontario Caregiver Organization's webinar series. These webinars bring together caregivers and subject matter experts to explore topics of interest to caregivers. We do this to support and engage chosen family, friends, and neighbors who are caring for someone. I'm Marnie Capacci, and I will be your moderator today. We begin this gathering by acknowledging the Indigenous peoples of all the lands that we are on today. While we meet on a virtual platform with people joining us from across the province, I would like to take a moment to acknowledge the importance of the land which we all call home. The land I'm standing on is the traditional territory of the Haudenosaunee and the Anishinaabe peoples, as well as the Mississaugas of the Credit First Nation, the Mississauga Nation, and the Huron-Wendat Nation, many of whom continue to live and work here today. This territory, covered by the Williams Treaty and Treaty 13, is within the land protected by the Dish with One Spoon Wampum Agreement. Today, this gathering place is home to many First Nations, Métis, and Inuit peoples, and acknowledging reminds us that our great standard of living is directly related to the resources and friendships of Indigenous people. As team members, we are learning about the lands from which we work, exploring how we can be meaningful allies, and how we can support the recommendations from the Truth and Reconciliation Commission. We do this to reaffirm our commitment and responsibility in improving relationships between nations and to improving our understanding of local Indigenous peoples and their cultures. We invite you to take a moment to reflect on the land where you are. And if you're not familiar with that, we'll be sharing an interactive map which tells you which traditional territory your city or town sits on. Our webinar today is called High Quality Care for Adults with Insomnia Disorder. As a caregiver, you may be supporting someone with insomnia, or you might have been diagnosed with the disorder yourself. Either way, it's important to understand the type of care you can expect from your healthcare providers. Knowing the quality standards for care is essential to both patients and caregivers to set your clear expectations. The OCO welcomes Ontario Health to discuss the new quality standard for insomnia disorder. This webinar will provide you with valuable tools, information, and resources. Today, we will be learning about Ontario Health's Insomnia Disorder Quality Standard and Patient Guide, key quality statements to improve care for people with insomnia disorder, programs, tools, and resources for caregivers, and lived experience from a caregiver navigating the journey. Our speakers today include geriatric psychiatrist Dr. Sophia Benjamin, who is an associate professor in the Department of Psychiatry and Behavioral Neurosciences at McMaster University and the Schlegel Chair for Mental Health and Aging. She is the co-founder and co-executive director of Geri MedRisk, and Dr. Benjamin's work focuses on implementing and integrating evidence-informed solutions at a system level for common challenges in older adults, such as polypharmacy and insomnia. She was the inaugural co-medical director at the Provincial Geriatrics Leadership Ontario and serves as a system leader in geriatric psychiatry. She completed her training in general adult and geriatric psychiatry at Duke University Medical Center in North Carolina, and her master's in health sciences through the Duke National Institute for Health Clinical Research Training Program. Her clinical practice is in the Waterloo region of Ontario. Dr. Colleen Carney is a professor at Toronto Metropolitan University and the director of the Sleep and Depression Laboratory. They are a leading expert on the cognitive behavioral insomnia treatment for those with comorbid illness. They have over 25 years of experience in behavioral sleep medicine with over 200 publications, including 12 books on CBT for insomnia. Dr. Carney writes treatment manuals and assesses fidelity in clinical trials, as well as trains students and professionals in behavioral sleep medicine internationally. They serve as co-chair on the Ontario Health Quality Standards for Insomnia and is a passionate advocate for improving access to evidence-based treatments for insomnia. Mafu Yakubu is a lead in the Clinical and Quality Standards program at Ontario Health. Mafu led the development of these insomnia disorder and palliative care quality standards. She is currently leading the development of the Cancer Survivorship Quality Standard and updates to the Low Back Pain Quality Standard. Mafu has also shaped the provincial implementation of the Sickle Cell Disease Quality Standard, including the implementation toolkit development, the Sickle Cell Disease Community of Practice, and evaluation of implementation initiatives. Her leadership continues to drive evidence-based improvements through inclusive collaboration and key partner engagement. Jessica Ostrega is a senior specialist in the clinical improvement and informatics team at Ontario Health. She led the resource allocation, communication, and dissemination of the Insomnia Disorder Quality Standard. Jessica has also supported provincial quality improvement and implementation initiatives, including leading the sickle cell disease community of practice and implementation toolkit development, supporting the development of a sickle cell disease provincial model of care, and the General Medicine Quality Improvement Network. Her work reflects a strong commitment to system-level improvement through strategic outreach and program development. Our caregiver, Charmaine, is a mother and the primary caregiver of her mother. She works closely with her sisters to support and ease their mother's daily life. Charmaine is also a multidisciplinary artist whose work has been exhibited at major art galleries such as the AGO and other venues both across Canada and abroad. Her paintings, sculpture, and public artwork reveal the intricacies and complexities of the relationships between us and our environments. In addition to artistic practice, Charmaine is professor, teaching part-time at a college in Toronto. She is a member of a collective of artists who are also caregivers. These artists, caregivers, represent many artistic disciplines and occupations. They come together periodically to share their work, aiming to contribute new insights into the experience of caregiving. Charmaine continues to strive to maintain a meaningful work-life balance, placing caregiving at the heart of her daily life, but also looking into how to better take care of her own well-being. Thank you for joining us today, Charmaine. And to get us started, let's welcome Charmaine to share her caregiver story and experience. I'll pass it over to you, Charmaine.
Thank you. Thank you, Marnie, for inviting me to share my caregiver experience and my struggles with sleeping. And insomnia really is kind of new to me in that everyone knows the term, but to actually look into what that is. So I'm a caregiver, as you heard, of my mother. I'm getting some help from my sisters, but I'm the major source of support for her. And I also have a daughter who also needs some support. So I'm beginning to really understand what it means to be the sandwich generation. Alongside caregiving, I'm a visual artist. And at this late stage, my art is kind of picking up instead of like winding down. And it's a wonderful dilemma. I also work, as you heard, as a part-time professor, and that grounds me, makes me feel that I still have something to contribute to my students. It's a needed source of income as well, and it's a way that I try to hold space for myself because with caregiving, there's a lot of opportunities to lose yourself. I'm a part-time artist. In a group that Marnie mentioned, and we exhibit periodically. And through this group, I see the many different faces of caregiving. So I really believe art is one way that we can give another perspective on caregiving. And we come up with some really interesting things. We always have a response box, and we get a lot of responses from, people passing by, the public. But a surprising thing that I found was the number of young caregivers that are out there, young caregiving artists too. And so they need a lot of support. So I'm going to definitely share some of this with them. So I never imagined that these things would happen simultaneously, caregiving and, life and work at such an intense pace. And so, it is a busy life like most of us, but the doctor's visits, the interrupted nights, marking paper, studio time, the emotional and very physical labor that comes with caregiving is challenging. And so being sleep deprived is for me, it was just one part of that. And so not thinking of it as anything to, not really having time to think about it more deeply. So I have not been sleeping well for some time. And, people would suggest melatonin because I was thinking that maybe I was just having trouble getting to sleep, and maybe that was just the problem. And people love to recommend melatonin, so I took that. But what I didn't take into account was that, it just helped me get to sleep a little, but I was in fact waking up and lesson planning and designing in my head. And what I didn't understand was, the damage that that could cause. And so I said insomnia was not something I thought about deeply, but friends and family mentioned it as a possibility. When they began to notice the signs, the dark circles, lapses in memory, I began to notice those, difficulty holding thoughts. But really, I didn't even have time to think about how to change that until I really began to worry about my students. I'm responsible for teaching my students, and I wanted to show up and be the best that I could be. And I was starting to have physical and mental fatigue. So I finally went to my doctor, and I was diagnosed with insomnia disorder. And after that, a friend sent me some information on the quality standards insomnia disorder care for adults. And I decided to use it and just to at first track my sleep patterns. So that's what I did. And I was so surprised to see how little I was sleeping. It was, yeah, it became scary actually when I saw that. And I practiced some of those things. I now try to employ some of the suggestions, and I am starting to see a little bit better sleep some days, still figuring life work balance out. And because I really want to do my artwork, I want to do all the things that I want to do, and I want to give good care to the people I love and I'm in charge of. So thank you.
Thank you so much, Charmaine, for sharing your story with us today. We know how valuable it is to hear caregivers' stories, and so we thank you for that, for coming on today and sharing. I would also like to welcome Jessica and Mafo to come on to introduce more about the standard.
Thank you so much, Marnie. And thank you, Charmaine, for sharing your story on your journey with insomnia. It really highlights the need to why we need to improve care for people with insomnia disorder in Ontario. And would like to also share some data with you from Ontario, just to reinforce some of these themes that Charmaine has mentioned. I would also like to highlight that for the purposes of this presentation and based on Ontario Health's writing style, caregivers will be referred to as care partners. However, just note that they mean the same thing for the purposes of this for this presentation, and in this context, they're just used interchangeably. So just let's dive in. According to the Canadian Community Health Survey, 1 in 5 adults in Canada have insomnia. And also there are 20% of adults in Ontario reported having insomnia, which was defined as trouble going to sleep or staying asleep most of or all the time. And from the graph to our left here, we see that the prevalence of insomnia is higher for women compared to men. And just the survey also indicated that lower socioeconomic status has been associated with poorer sleep, with factors such as irregular work and living in noisy or unsafe environments affecting sleep. There are also other factors indirectly affecting sleep, such as stress, health behaviors, and comorbidities that disproportionately affect people of lower socioeconomic backgrounds. Now, when we look at the impact of insomnia, it affects people's daily living. Now, according to 2 longitudinal studies, people with insomnia are more likely to report dissatisfaction with life, psychological distress, poor energy levels, and so on. And there are other impacts of insomnia, including vehicular accidents, workplace accidents and injuries, and work absenteeism. The graph to the right is also from the Canadian Community Health Survey, and it displays that when we compare people with insomnia and with people that don't have insomnia, they have significantly higher poor or fair perceived general and mental health. There are also societal and economic impacts related to insomnia. In Canada in 2021, the economic impact of insomnia in relation to people with comorbid chronic condition was estimated to be $1.9 billion. And this includes both direct healthcare costs and indirect costs in terms of labor force. It was also estimated that if we reduce insomnia by just 5% in the population, we would save at least $350 million per year. So there are also gaps related to the treatment of insomnia. So there's evidence, it's really strong, high and quality evidence that have demonstrated that CBTI is recommended as first-line treatment for insomnia, but there are gaps related to access to CBTI. In Ontario, only 8% of adults with insomnia reported receiving healthcare regularly from a psychologist or mental health professional. This is as of 2021. And then with people with insomnia, they can also face financial barriers accessing CBTI treatments. People also often don't know who and where to seek for insomnia disorder care, and people are misinformed about insomnia treatments. Some also misunderstand insomnia as just something due to their lifestyle. I think Charmaine spoke a little bit around that, and sometimes they feel responsible for not being able to have restful sleep. So these are some of the gaps just related to having insomnia and accessing treatments to insomnia, that's CBTI. Also, there's also a need to improve clinicians' knowledge about insomnia treatments. According to a survey in 2019 among clinical psychologists in the US and in Canada, they found that 64% recommended sleep hygiene to treat insomnia and only 17% over CBTI. Even though sleep hygiene has been shown in the evidence not to be effective as a standalone treatment, we're seeing that this is really high in terms of recommendation for treatment instead of CBTI. So when we put all this together, the lived experience story that we heard from Charmaine, the prevalence of insomnia, the societal and economic burden of insomnia, and just gaps in terms of treatment, they all highlight why we need a quality standard for insomnia disorder. And Ontario Health developed this standard and released it early this year to address these gaps. If you've never heard of Ontario Health's quality standards, they are a small set of statements that describe what the best care is for a given health condition or process of care. For example, we're talking about the insomnia disorder quality standard, but there's also a standard for diabetes, schizophrenia, and so on. And the quality standards, what they do is to inform clinicians and patients what high quality care looks like. And they focus on topics where Ontario data shows that patients receive care that was different from the care depending on where they live or where there are gaps between the care that they should be provided and the care that they actually receive. Now, all the quality standards are grounded in the best available evidence using clinical practice guidelines, as well as clinical expertise and lived experience from that all come together to inform the quality standard. So in short, the standard set a standard for how care should be delivered, no matter who provides the care or where a person lives in Ontario. And so far, the quality standards that we have in the libraries for the quality standards have been released to date from Ontario Health. Now, for the purposes of our presentation here, we're talking about the insomnia disorder quality standard, and we've defined this as distress or daytime impairment that lasts 3 or more months, and that is associated with one or more of the following. So difficulty initiating sleep, difficulty maintaining sleep, or early morning waking with difficulty returning to sleep, despite adequate opportunity for sleep. In terms of the quality standard, the scope includes just addresses care for people or adults aged 18 or older who have this condition, insomnia disorder, also known as chronic insomnia. And the quality standard applies to all healthcare settings. The quality standard does not include care for people whose sleep difficulty is better explained by different sleep disorder. Now, the quality standard, as I mentioned, it outlines what quality care looks like for a condition or a topic based on evidence. And when we release a quality standard, it's accompanied by an assortment of resources. So we've already highlighted the quality standard, but there's also a patient guide that summarizes the quality standard in plain language to support patients, family members, and care partners. We also have a placemat that is a clinician resource, about 2 pages, that is a high-level summary of the quality standard and includes some resources for clinicians to implement the quality standard. There's also a case for improvement deck. There is a slide deck that can be used to make a case for why quality improvement should be done in this area. There are also implementation resources. There's a measurement guide, the technical specifications, as well as a getting started guide that provides implementation support, how to get started with implementing the quality standard. Now, to develop the Insomnia Disorder Quality Standard, Ontario Health recruited an advisory committee. I think I alluded to this earlier, where we said the quality standard is based on best available evidence, clinical practice guideline, as well as clinical experts. So the clinical experts, as well as people with lived experience, all come together to have the quality standard advisory committee. And the committee include, like I mentioned, lived experience. We had 2 lived experience advisors in this committee. And the names of all the members of this committee are listed here, but you can also access this on the Insomnia Disorder Quality Standard webpage. The QR code there will link you to the webpage with these names here. And we are pleased to have 2 of the co-chairs from the Insomnia Disorder Committee, Quality Standard Advisory Committee here with us for this presentation. So Sophia and Colleen are here. So now we're going to take a deeper dive into the quality statements and what they mean for patients and care partners. We're also going to be highlighting tools and resources that can make it easier for care partners to better support themselves or their care recipients in managing their insomnia disorder. So in the Insomnia Disorder Quality Standard, there are 5 quality statements, and they include the following topics. The first statement is around comprehensive assessment. The second is on individualized person-centered comprehensive care plan. The third statement is around managing insomnia disorder in people with comorbidities. The fourth statement is around treatment with cognitive behavioral therapy. And the 5th statement is around pharmacotherapy. And now I'm just going to pass it on to my colleague, Jessica, to share the statements in detail, what they mean for people with insomnia and their care partners, and just resources to make it easier for people to support themselves, either in treating insomnia or managing insomnia for their care recipients.
Thank you very much, Mafo. So I'll first start by announcing and congratulating Sophia on the draft comprehensive sleep assessment and treatment algorithm that she's been working on. This is a color-coded system emphasizing cognitive behavioral therapy as a standard of care and listing interventions in separate boxes, but also provides a hyperlink to the quality standard and other useful resources for clinicians. So I'd like to invite Sophia to speak a little bit more about this algorithm and provide her thoughts.
Thank you, Jessica. And really, it's been a joint effort with Dr. Carney and her team, as well as the Canadian Sleep Research Consortium. So what we've done is taken the standards and tried to create a pathway that a family physician can quickly read while you are presenting to them with an insomnia symptoms. And so it's not the final draft yet. We're still tweaking it a bit, hoping to include a lot of the resources that will be mentioned later, including links to drug information, as well as a CBTI provider map. And this is the non-graphics version, so we're going to make it look better. But what we've done is we've gotten feedback from various family physicians, as well as the Older Adult Insomnia Collaborative, so that it's gone through several rounds of feedback. So hopefully it will be in clinicians' hands soon.
Thank you, Sophia, and thanks, Sophia and Colleen, for your work on this. I'll start with quality statement 1. And as
as Charmaine alluded to, a sleep diary is a very useful tool for being able to begin the comprehensive assessment or understanding of someone's sleep patterns. So people suspected of having insomnia receive a comprehensive assessment to inform that diagnosis. What that means is that your clinician or the clinician of the person you're caring for should talk to you about your sleep and how it's affecting your daily life. They should ask you or the person you're caring for about your sleep history and your medical history, including physical and mental health symptoms. And where a sleep diary can become very helpful is better understanding those sleep patterns. I'd like to invite Colleen to speak a little bit more to that.
Thanks, Jessica. Yeah, if somebody receives the diagnosis, then this is a pretty important part of treatment that we would actually, because CBT is really about learning together what your experiences and patterns look like, and then to make some adjustments to see if that's helpful. At the doctor's office, you're unlikely to probably complete a sleep diary. If you're doing self-help, then there's things like consensussleepdiary.com or other resources where you could actually track your sleep.
Thanks, Colleen. So moving on to statement number 2. So individualized person-centered comprehensive care planning. So people with insomnia disorder, care partners as appropriate, and clinicians collaborate to develop an individualized person-centered comprehensive care plan. They review this plan together and regularly. So what that means is that your clinician should work with you and the person you're caring for to make sure that they're creating a plan that fits the values of yourself and the person you're caring for, their wishes, goals, and needs. So the patient guide really provides a good tool to help guide the discussion with specific, suggested discussion questions or discussion points, and also an elaboration on what each statement looks like when you're actually in a clinical setting. So thank you, Mafa, for including the link for the resources as we go through them. And I think we'll move on to the next set of statements. Thank you. So for quality statement 3, managing of insomnia disorder in people with comorbidities. So people who have insomnia disorder and comorbidities receive that timely treatment for their insomnia and any other health conditions as part of a comprehensive care plan. So this simply means that all the other situations and disorders or challenges medically that a person is facing don't get ignored, but get treated at the same time as your insomnia. And this goes along pretty well with quality statement number 4, with cognitive behavioral therapy for insomnia really being the beginning point of treatment. So people with insomnia disorder have timely access to cognitive behavioral therapy for insomnia as first-line treatment. Therapy is delivered in a way that best fits the person's needs and preferences. So your clinician should offer CBTI as soon as possible after diagnosis in a format that best fits your needs and preferences if possible. One of the resources that Colleen and her team have worked really well on, and it's an incredible resource overall, is the provider map of cognitive behavioral therapy for insomnia nationally. And you can see that in the first QR code link there. It's a great resource. And Colleen, I'd love for you to elaborate a little bit more on that and speak to those 2 statements.
Yeah, I think the main thing I would say is that oftentimes providers think that there's no one out there that can provide CBTI. And so we started putting this map to show that there really are quite a number in Ontario that can provide it. It may cost you out of pocket, but it is a very brief treatment and insurance can cover it. So it really depends. And the whole idea about preferences in terms of delivery, it's also an effective treatment when it's done in self-help, like whether it be a book, and we have, Sink into Sleep or Quiet Your Mind and Get to Sleep in Ontario. The 2 authors are in Ontario, or digital delivered CBTI, something like Sleepio, which is paid. So there's different versions that you can get other than necessarily going to a provider, but the provider map will give you some information. And the comorbidity, I think, is so important because unfortunately, it's usually the other way around, wherein the insomnia is not treated. It's the other thing that's always treated. So I think this really explicitly says, yes, you may have depression, you may have chronic pain, but if you have insomnia disorder, we're not going to ignore that. We're going to treat the insomnia disorder because CBTI is very effective, even in people who have lots of other things going on.
Thanks, Colleen. And I know you mentioned like digital tools such as Sleepio, and we do have the CBTI app here that you were part of developing also. Could you give a little more guidance for how caregivers or care partners can approach using an app like this to support themselves and how best to work with their care teams to use an app like this?
So this one is actually from something from the US in the VA. It's a training program that we made down there. And this is just something that you can use alongside while you're doing CBTI. The consensussleepdiary.com, I think I like a little bit better. So it's a little bit awkward right now, but it is pretty good. Providers do like it because it's got a lot of bells and whistles with it. I think that's not usually what we would use. We would usually use the diary one, but there's other ones though that have its digital treatment on its own.
Thanks, Colleen, and appreciate that precursor too, to be able to consult with your care provider to make sure that you're aligned on what you're using and what tools you'll be using to support yourselves. So now I'll move on to quality statement 5 on pharmacotherapy, that people with insomnia disorder are offered effective medications at the lowest possible dose for the shortest possible duration and after an adequate trial of cognitive behavioral therapy for insomnia, and that a medication is offered only after a good discussion of the benefits and risks. So essentially that your clinician really talked to you about medication options, about the risks of those medications, and that treatment plan is discussed early on. And I do have the resource that Jerry Medrisk and some of Sophia's team worked on, which is common medications that manage insomnia disorder. So I'd love for Sophia to elaborate a little bit more on that and give other points that people should be thinking of as they're supporting, their loved ones or supporting the people in their lives in providing that care.
Yeah, so unfortunately, many individuals with insomnia, when they present to a physician or a prescriber, may get offered a medication instead of CBTI. So really, we're hoping that this standard guides them away from that practice. And when they prescribe, that they really know about the individual medications that they are recommending. And so the information page that we created is actually focused primarily on prescribing to older adults who are an even more vulnerable cohort because of the effects of medications on them, because they can have confusion, falls, delirium, even on doses that may be tolerable to someone in their 30s or 40s. So we want clinicians to be extra cautious. And this page also differentiates between medications that are commonly prescribed but are actually not recommended, or we actually recommend against using some of those medications because they cause side effects, but they've actually not been shown to be effective in insomnia. So those are all the types of information that is available in that page. It is clinician facing, so it goes into details about the dosing, drug interactions, the way the drug is metabolized. So generally, it's meant for a prescriber audience. And so we hope that physicians, nurse practitioners, pharmacists will use those, and that will guide discussions with patients and caregivers. Thank you.
Thank you, Sophia. So moving on to the last slide on accessing some of these tools and resources. So the patient guide can be available at the link that I shared. It is one of the resources that are part of the entire quality standard, as well as the placemat, which is a clinician framed tool that's just a one-pager that's very easy for you to share with your clinical team to help support your journey and treating your insomnia, and to make it imperative at this point to be mindful that insomnia can not just affect the person you're helping care for, but also yourself, right? And as Charmaine has alluded to be mindful of your own sleep in your caregiving process. And then finally, I would like to point towards a separate link in Quorum, where some of the other resources that are paid or behind a possible paywall, like books, like Sink into Sleep or Sleepio, those will be listed on Quorum as well. And that resource is a little more is updated more frequently as resources come up, but that all these resources are available through these links. Thanks, Mafo.
Thanks so much, Jessica, Colleen, and Sophia. We've just posted the email. If you have any questions around the quality standard, if you have any comments, please email us at this email address that we've linked here. I think now we just have some questions and answers. So I'm just going to take down the slides and pass it on to Marnie.
All right, thank you so much. Thank you, Jessica, Mafo, Sophia, Colleen, for sharing the information for today's webinar. Please note also that today's webinar is for general information purposes, and we always recommend speaking to your healthcare provider as well. Now, let's get to our questions and answers, and I would like to invite and welcome everyone back on camera to join me for the question and answer segment. And just before we get to the question and answer, are there any follow-up remarks that you want to make? Any information that you wanted to share that we didn't get a chance to share before we go into some Q&A? Sophia.
Yeah, one thing that I would add, which I think is very pertinent to the caregiver group, is often I see individuals who are struggling with different types of dementia. And that's closely linked with many sleep disturbances. And I see that caregivers of people living with dementia in the community, they struggle with sleep because they are awake with the person they are caregiving to, and two things that can happen as a consequence. Someone can provide care or be a caregiver for 8 hours a day, 12 hours a day, but when the person is not sleeping, then it becomes a 24-hour day job, and that can get very stressful very soon. And we are doing some work to develop interventions that will hopefully help both at the same time. And they may look a little different. So, for example, someone who is struggling with dementia may not be able to participate in standard CBTI. However, the caregiver can get CBTI during that time. And then the second observation is, the person with dementia may then go to long-term care or a retirement home. But if the person who was the caregiver, who's now had sleep disturbances for 6 months or a year or 2 years, they could go on to have chronic insomnia if they don't get treated. So I think that's another maybe observation that's specific to caregivers. Thank you.
Thank you so much for sharing that, Sophia. Jessica, is there anything else you wanted to add to that? No? Okay. So one of the questions that I had, and please, if you have any questions, you can type them into the chat. I'm taking a look. Then Charmaine, maybe I'll ask you, or if any of our other panelists want to join in. What is one thing that you learned from the quality standards that maybe would have helped you if you could have learned this earlier in your care journey or in your experience? And so, Charmaine, is there anything that you maybe want to add that would have been, helpful if you had known earlier?
I'm just going to say there's a lot of things that would have been helpful. Yeah, because after not sleeping well for 2 years and you finally get some information, like just to get the information, like didn't I know that this information was there, first of all? And then what was useful, I mentioned before, just like having a chart to sort of actually see, like I had no idea that I was having so little sleep, and just to start to track it was, just such a benefit for me to take it seriously, I think.
Yeah, thank you, Charmaine. And yeah, it definitely is so important. The quality standards, many of the quality standards that we've talked about here at OCO are exactly as you said. It's when you learn about what's available to you and puts you on maybe a different pathway than you expected, and hopefully to help support you as you move along your journey in caregiving, as well as your own personal experiences. So thank you so much for sharing that, Charmaine. For Jessica and Mafo, could you maybe, we talk about CBTI and other, in the treatment, could you address if there are any issues with fees or costs or suggestions from the quality standard?
Thanks so much, Marnie. I think that's one of the gaps that we had highlighted as to why we need the quality standard, is that CBTI is first-line treatment, but we're seeing that there's barriers to even accessing it, financial barriers, as you mentioned, or another work that Colleen highlighted is just that provider map just being available is people don't know, so they can't even access what is even available in the first place. So one thing that I can speak to a little bit is that we're working with system partners. Sophia is and Colleen are also working to just see how to we have the quality standard as a base to advocate for CBTI, because it is first line treatment. So we have the quality standard to advocate for that treatment. And now that we have this tool that's a quality standard, we can put it in different places, whether it's with the ministry, whether it's with other clinicians, to see if there are other ways that we can have implementation strategies to make sure that we're breaking down those barriers to accessing this first line treatment. So there's still things going on in the background for now, but right now I think, so Colleen's hand is up right now, but right now I think starting off is the map that is available to say, okay, this is what we have for right now. But I know that we are working with system partners to help advance the access to CBTI. I think I'll pass it on to Colleen because this is her baby.
Thanks, Mafo. Yeah, so there are those initiatives. There's also, I think maybe it's helpful to understand how brief it is too. So the typical model is actually 4 sessions. So if you were to actually see somebody in the community from the map, it wouldn't be unusual to even do 2 to 4 sessions. It works very quickly. And so that might be a cost, and that might be cost prohibitive. One thing that I will say is my lab, which is called the SAD Lab, so sadlab at torontomu.ca. We always have free CBTI going on, always. And that's been a commitment since I returned to Canada in 2008. We always have something going on. So, and we do it virtually. So in Ontario, that's always an option. So that's something to think about. And as Mafo was saying, there's different people in the healthcare system where it is actually covered. So we're trying to make sure that people get trained in those where it is OHIP covered. But we're also looking to try and expand so that even when it's delivered by a psychotherapist, that it might be covered as well. So we're working on it right now, but the cost of that would be, to me, on the order of what you would spend on sleep medication for long-term use for, doing the 4 sessions.
Yeah, thank you, Colleen. I mean, it's when it was laid out in the information that the effectiveness of the CBTI versus pharmacology or the pharmacological interventions, it's quite astounding, the difference. And certainly from a cost perspective, many caregivers or the recipients may not be able to even pay for a drug or for medication as well, but thinking about where there might be access to free treatments, free support, and we will provide a link to any of those resources and materials in the post-webinar email that we'll send out in the days following, with a link to the recording as well, and a link to the documents, to the resources, and to all these things. So I really do appreciate that, because sometimes when the idea of CBT or therapy or any kind of therapy, and the thought would be that, yes, it might be cost prohibitive, but understanding that, well, it could be as short as 2 to 4 treatments, that's actually quite manageable. And again, when caregivers have a lot going on and they're busy and their schedules are busy, and we talked about just recently, just exactly as you mentioned, sometimes it is a 24-hour responsibility. and even to find an hour to do CBTI might be very overwhelming and difficult. But knowing that there is support and access to those tools right now can be very, it can sound like a little bit of ease. And so I thank you for that. Thank you. Anything else to add on that conversation before we go to the last question? And someone did just ask if someone could please repeat the name of the OHIP covered CBTI program. If that's, I'm not sure if there's an OHIP covered one, but there may be. I think, Colleen, I'll let you rephrase.
Yeah, I think maybe it was referring to there are different disciplines that can provide CBTI, and it is OHIP covered. And I actually, the exact same email that I gave for the free CBTI, you can actually use to ask about resources. So we actually maintain a list of OHIP covered people. They do have long lists, and so that might not be a great option, but that if you are to email our lab and ask for that, for those resources, you can have those.
Thank you for that. Thank you. And again, as I mentioned, today's information is for general information purposes. And definitely, speaking to your healthcare provider, starting the conversation, and then knowing with the quality standard, in hand, you can start, having more of a conversation, a deeper conversation, because you may now have more tools that you didn't have before. Is there anything else? I know we're coming up close to time, but we have time for another question or two. And my last question really from me is there anything else that you would like to share, knowing of, what we've talked about? And thank you everyone for sharing with the focus towards caregiving and caregivers today. Is there anything else you'd like to share? Any second mentions, anything else that you'd like to add today? Oh, Colleen.
I might just make this one clarification, because I think I run into this all the time, where somebody says, well, of course I can't sleep. I am under stress, or I'm interrupted several times a night to go to provide care. And what I will say is that it's the same thing even when you're caregiving for a new infant. The act of having to get up or being interrupted in order to take care of something is certainly stressful. However, that's not insomnia. What we're talking about here today is that those interruptions over time can develop into a difficulty falling back to sleep. So if you're somebody that is interrupted several times, and so you're sleep deprived, then I think certainly getting help with respite when you can, with maybe even investing in some monitoring tools to see if somebody's getting out of bed or something like that, whatever would be helpful for that. That's one aspect. But then there's when this problem turns into something chronic, wherein now you've done the caregiving, you've gotten back into bed, and now you can't get back to sleep. That's what insomnia is. And it is something that is treatable. And we can't get rid of the interruptions for caregiving, but we can get rid of the prolonged stuff after that. And I think just making sure that you get help for that, because caregivers, of course, burn out very quickly with everything they're doing, and thinking that, oh, well, there's no hope for me. And there really is.
Yeah, thank you for that, Colleen. And as well, we have resources here at OCO. We'll share all of that in our post-webinar email as well. Is there anything else that you wanted to add, Jessica Maffo, with regards to the standard? Sophia, if there's anything more that you wanted to add with regards to the work you're doing, Sophia, yeah.
Yeah, I forgot to mention this, but there is, I'm not sure if you've heard of Caregiving Strategies, which is a course that is offered by Provincial Geriatrics Leadership Ontario. I'll try to put the link here. So they have chapters on different aspects of caregiving, usually for older adults, so like pain, nutrition. But now we are writing a chapter on sleep as well. So that will be up updated like in the next year. And they offered both as a course, but there's also an online version, like the PDF that folks can read. So that may be a resource that is coming soon.
Thank you so much, Sophia. That's a great resource. And I think it's really, really important that for many caregivers who may need a virtual option, who may need an option where they're not able to leave the home, or for those who feel like there might be a situation where they can get out and they can find that information too. I think the multifaceted approach of either virtual or online or in person is very, very helpful. This one question just came in. I know we still have another minute or two. Can a person do a self-referral to a CBTI clinic, or does it need to be a doctor referral? That's a great question.
A lot of the providers would be therapists, psychotherapists, and so therefore a self-referral works well. It's really only I can't even think of a situation in which you require a referral for this. I think it's self-referral primarily.
Yeah, for most of the psychotherapists in Canada, is you can just self-refer. I like to use the case example of my mom. My mom is that sandwich generation, right? She takes care of myself. She takes care of, my brother. She also takes care of all our grandparents and everybody who needs her care. And she's been living with insomnia as long as I can remember. I don't think I remember a day in my life where I asked my mother how she slept, and it wasn't a positive description. I was lucky enough to be part of working on the quality standard and all the incredible work that Mafo, Sophia, and Colleen have put into developing this, and was able to share that CBTI map with my mom. She got CBTI. She self-referred herself, started working with a psychotherapist in Hamilton, and over the past 2 months, I've actually been able to talk to my mom and have her come back to me and tell me she's sleeping great. She's sleeping well. So it does work. And it is a little time consuming. It takes a few weeks to really get the process going. But these tools and all these resources that are available here, if implemented well, and if you take the time to really take care of yourself in the process of taking care of everybody else in your life, which I'm sure so many of the caregivers on this call do, you can sleep again. Yeah.
Thank you, Jessica. I think that's a great experience to share. I think it's so valuable to hear that it does, anything in what we do to try to ease a journey or to help support someone who is caregiving. It does take time. It doesn't happen overnight. This is hard work, just like everything, right? So it's one more piece, but when it's you, as a caregiver, if you're experiencing this, it's a benefit. It's definitely a benefit. So with that, I want to thank everyone for joining us today. We so appreciate the conversation, the expertise, the experience today, and all of the valuable information that has been brought together. So on behalf of OCO, I really want to say thank you for joining us and for sharing this information today.